Good morning, everyone, and welcome to the MQ Health Wellness Series, Women and Cancer, Screening, Prevention and Treatment. I'd like to start with our welcome to country.
Welcome. We acknowledge the traditional custodians of Macquarie University land, the Wadamadigal clan of the Darug Nation, whose cultures and customs have nurtured this land since the Dreamtime. We pay our respects to elders past, present and future. We welcome people of all nations and all faiths. Kwai Bidja, Jamna Payala Janawi. Come here, we speak together. We have 60,000 years of archaeological evidence of Aboriginal habitation at Lake Mungo and 20,000 years in Ryde. We have great antiquity. Today, hundreds of Aboriginal and Torres Strait Islander people graduate from Macquarie University. The Darug Nation had famous leaders such as Chief Yarramundi, Naraginji, Colby and Maria Locke. Many of the descendants of these Darug people live today amongst you. We celebrate with you our ongoing attachment and custodianship of this country. We celebrate the achievements of Macquarie University.
Thank you. My name is Dhanusha Sabanathan. I'm a medical oncologist here at Macquarie University. Today we'll be talking about women and cancer. I'll be starting off today's wellness series just giving you a brief overview on the preventable causes of cancer in women and the importance of cancer screening in women. And then I'll be joined by two of my colleagues to delve into a bit more detail into the breast, ovarian and cervical cancer screening programs. So my overview, we're going to cover very briefly skin cancer, breast cancer, bowel cancer, lung cancer, cancer of the uterus and ovarian cancer and cervical cancer. So starting off with skin cancer. As we all know, exposure to ultraviolet radiation accounts for approximately 95% of skin cancers in Australia. Ultraviolet levels in New South Wales alone are high enough over 10 months of the year to attribute to skin damage. So, as we've all heard of, including my 9-year-old who was with me while I was preparing these slides, slip, slap, slop, seek and slide. And for those of you who aren't familiar with that, that's sunscreen, put on a hat, slop on some long sleeve clothes and pants, seek some shade and slide on a pair of sunnies. There is no national screening program for skin cancer. So look out for these signs or symptoms. Be aware of your own body. So if you notice a new spot or a lump on your skin, a spot that looks and feels different from other spots on your skin, a sore that doesn't heal within a few weeks or is getting worse with time, or that has changed in the size, shape, colour or texture, or it becomes itchy or it bleeds, see your doctor if you have concerns. Moving on to breast cancer, which we will go into in a little bit more detail. The breast cancer is the most common cancer diagnosed in Australian women. It is most common over the age of 50, but it can affect a woman of any age. Reducing your risk, and a lot of these things will be repeated a number of times over the next few slides, but maintaining a healthy weight and being physically active attributes to most of the risk reduction. Aiming for approximately 60 minutes of moderate exercise or 30 minutes of vigorous exercise on most days will help. Drinking alcohol increases the risk of many cancers. The more you drink, the greater your risk. If you do drink alcohol, try to stick to the National Health and Medical Research Council guidelines. If you do have a family history of breast and ovarian cancer, talk to your doctor about how you need to be screening yourself. And be aware, again, of your breasts. Regularly checking them and knowing what is normal for you helps find any new or unusual changes. Now moving on to bowel cancer. Again, bowel cancer usually affects women greater than 50 years of age. However, there is recently a trend towards diagnosis at a younger age. And again, like I said, reducing your risk involves a healthy diet, so avoiding processed meat and variation. So ensuring a variety in your diet with less red meat, physical activity, drinking less alcohol again, not smoking, and taking part in the National Bowel Screening Program. Again, if you have a family history of bowel cancer, talking to your doctor, if you do have that strong family history, to discuss screening programs is important. Lung cancer. An interesting fact to note that rates of lung cancer in women are currently going up, whilst rates in men go down. Tobacco smoking is associated with 65% of the lung cancer in women. However, non-smokers can get lung cancer too. Reducing your risk. So smoking is the biggest preventable cause of cancer in general. Smoking is associated with chances of developing many types of cancer, including lung, but also bowel, cervical, ovarian, bladder, kidney, liver, and many of the gastrointestinal cancers, including esophageal, pancreatic, and stomach cancers. Quitting smoking is one of the most important things you can do to reduce your risk of cancer. And quitting smoking at any age will benefit your health. Avoiding passive smoking, and in the case of occupational exposure to cancer causing dust, wearing personal protective equipment or PPE is extremely important. Otherwise, if you have a strong family history of lung cancer or have a history of other lung disease, talk to your doctor about screening. Cancer of the uterus, also known as endometrial cancer, is also common in women over the age of 50 years of age. The most important risk factor for endometrial or uterine cancer is obesity. So maintaining a healthy weight and being physically active is extremely important to reduce your risk. If you do have a family history of any cancer that may be linked to a syndrome known as Lynch syndrome, talk to your doctor to discuss screening methods. Ovarian cancer is more common after menopause, but can affect women of any age. Reducing your risk, again, is associated with maintaining a healthy weight, being physically active, quitting smoking, and again, talking to your doctor if you have a family history. And last but not least, cervical cancer. Almost all cases of cervical cancer are caused by human papillomavirus. Women aged 25 and above participate in the screening program even if you have had the vaccine. Quitting smoking also helps in reducing the risk, and talking to your doctor about avoiding the long-term use of the oral contraceptive pill if you do have a diagnosis of prior HPV infection is important. So cancer screening. Well, why do we do cancer screening? Cancer screening detects cancer at an early age. It's looking for a cancer before a person has any symptoms, and the aim is to reduce illness and death from cancer. The reason for that is because we can find abnormal tissue or cancer when it's early. It may be easier to treat or cure. By the time symptoms appear, there is a possibility or a higher risk that the cancer may have grown and spread. And to talk further about ovarian and cervical cancer screening and treatment, I would love to introduce Abby Fyfe, one of my dear friends and colleagues at Macquarie University. Abby is the oncology clinical nurse consultant. She's worked in cancer services for over 20 years, both within Sydney and internationally in senior oncology nursing positions, giving her a vast quantity of experience across the spectrum of cancer nursing. She works together with the MDT to support patients from diagnosis through treatment and beyond. She is passionate about the patient experience and is involved in quality projects and strategic service planning to develop survivorship and supportive care programs. She has recently completed her Master of Cancer and Haematology Nursing and is the private sector representative and survivorship lead on the Australian and New Zealand Lung Cancer Nurses Forum Steering Committee. Thank you, Abby.
Thanks, Dhanusha, and thanks for the introduction to today's wellness series on women and cancer. So yes, I will be talking a little bit further and more about ovarian and cervical cancer screening and treatment. So just a very quick overview of where our cervix and ovaries are. I really hope you all know this, but just in case you don't, it's a very important part of our female reproductive system. The cervix is a connective tissue and muscle. It connects the uterus and the vagina. It allows flow of blood and secretions out of the body. It closes tight during pregnancy to keep that baby in and widens during childbirth to help get that baby on out. Our ovaries produce our oocytes or eggs for fertilisation, which then go on to become a fetus. It also produces our reproductive hormones essential for us females. Very quick overview for us on where these cancers sit in incidence in Australia. So the table on the left is Australia's most commonly diagnosed cancers for 2022 across all persons. And ovarian cancer, you can see, sits in number 19. The table on the right is for females, so same incidence commonly diagnosed in 2022 per 100,000. And again, now ovarian moves up the table to number 9, and cervical is about number 13. And of course, like Dhanusha mentioned, breast is number 1 for females. This is just to do a bit of a comparison between the two cancers. As you can see, so some very, very brief details there on what incidence and mortality. Cervical has a much lower incidence and a much better mortality than ovarian cancer. It does have a better 5-year survival rate, 74% versus 48% for ovarian cancer. The lifetime risk of being diagnosed and of dying of these cancers is better for cervical again. And the mean age of diagnosis is slightly different, 50 for cervical and ovarian is 66. So a little bit of a slightly better story for cervical cancer than an ovarian. So let's talk a little bit more about cervical cancer. Some more general stats on cervical cancer. It is the sixth most common cancer in 20 to 39-year-olds. The mortality is higher in the Indigenous population and in very remote women. And the 5-year survival is worse for Indigenous women. And we may touch on why that is, why that occurs. It could be an access thing. We do see as well that the lifetime risk and the risk of death has reduced in the last 40 years, and there's a really dramatic drop in the 90s. So this graph, shows you the incidence from 1982 to 2018, and you can see there that there's a big drop-off in the 90s for incidence in Australia. So what are some risk factors for cervical cancer? Anyone born with a cervix is at risk of getting cervical cancer. As Dhanusha mentioned, human papillomavirus is a big risk factor, and other STDs can contribute as well. Sexual intercourse, multiple pregnancies are a risk factor. Anyone with a weakened immune system, long-term use of the contraceptive pill, smoking and age are major risk factors. What symptoms would we look out for? Unusual vaginal bleeding, unusual vaginal discharge, painful sex or pelvic pain. So these would be things that are unexplained and persistent to the norm. If you did get diagnosed with a cervical cancer, there's a range of treatments that would be offered. The main treatment would be a surgery where possible, and that's normally for people with a localised or a small cancer at an early stage. And they do really try with these surgeries to spare that fertility if possible. There might be other treatments that you'd be offered, some radiotherapy, chemotherapy. There's targeted therapies depending on the biology of the tumour itself. Immunotherapy, which targets the immune system to fight against that cancer cells. And then there's clinical trials that are looking at the role of immunotherapy and more targeted therapies that are coming out now. So these treatments, as you may imagine, might have a range of side effects. And they could be acute, they could be long-term, they could be late. It could just be localised to the area that's being treated, or it could affect the whole body. But there's a major impact on women for these side effects. So as you can imagine, there would be lots of issues with pregnancy, particularly if the surgery is having to remove a large tumour. Chemotherapy and radiotherapy can also affect pregnancies or possible pregnancies. Early menopause. Some of the treatments can cause vaginal dryness and narrowing of the vagina. There might be some muscle dysfunction in the pelvic floor. There might be some lower leg swelling, which we call lymphedema, because they do remove some lymph nodes during surgery often. And a lot of these treatments can cause fatigue. So as you can imagine, there's a major psychosocial impact on women, particularly around body image, maybe the ability to perform our usual tasks, our work, and may have a major impact on sex and our relationships and intimacy. So what is human papillomavirus? It's a STD. It's contracted during skin-to-skin contact. It's generally asymptomatic. You wouldn't know you had it. And it generally self-resolves within 1 to 2 years if we have a good, strong immune system. So that goes back to that risk factor of having a weakened immune system. It can take 10 to 15 years to develop into a cancer if our immune system isn't strong. And we do know now that 70% of cervical cancers are related to this virus. And the discovery of this association of the virus to cancer has really assisted with better outcomes. Screening. So we in Australia are very lucky. We have a national cervical screening program. It was introduced in 1991. Initially, it was offered to 18 to 70-year-olds who were sexually active and consisted of a pap smear, which was doing some scrapings of the cervix, the cells of the cervix, every 2 years. And it was looking for any abnormal cells. During these testing, it found a lot of association with the HPV virus to cervical cancer, so the screening program changed in 2017. It's now offered to 25 to 74-year-olds. It's a cervical screening test every 5 years, and it's specifically looking for the HPV virus. In 2018 to 19, 3.1 million women participated in the national screening program, which is 46% of eligible women. For every 1,000 people screened, 9 had a high-grade abnormality detected. And we know that women diagnosed through a screening program have a 77% lower risk of dying from cervical cancer, which is a pretty good statistic. We do know as well that in 2020 there were fewer screening tests. Not really sure at this point whether it's from COVID or changes to the screening program in 2017, but there's a thought that we'll see a flow-on effect in the coming years and maybe find a better association. The vaccine. So the more we found out about HPV associated, the more we could find some preventative treatments. So there's now a vaccine. It protects against 9 different types of HPV that's known to cause 90% of cancers. It was introduced in 2006 and provided to persons aged 12 to 13 years of age in a school-based program. It's free for all persons between 12 to 25 years old. However, as Dhanusha mentioned as well, you still need to participate in that screening program from 25 years of age. We know that incidence and mortality of cervical cancer has halved since both of these initiatives have been introduced, and more information can be found on the Cancer Australia website. So here's that graph again on the incidence trends. You can see the first arrow is when the screening program started and that massive drop-off in the 90s. And then the vaccination program is the second arrow, and we can see the changes across that trending. So it's a really good story. Now we're going to talk about ovarian cancer, slightly different story. We went through some incidence and mortality stats before and saw that it's not as great as cervical cancer. However, 5-year survival has improved in the last 25 years, and there's a really great increase in the 2-year survival numbers as well. 5-year survival is best in early stage disease, so the earlier it's found, the better the outcomes. However, it is still the 5th leading cause of death in Australian women. Over 80% of women relapse because of this high rate of resistance to chemotherapy. And there's lots of different subtypes of ovarian cancer with a very differing prognosis and a response to treatment, so it's quite varied. What are the risk factors for ovarian cancer? So age over 50, genetics. So if there's a BRCA or a Lynch syndrome, we know it accounts for about 20% of cases. Endometriosis and breast cancer, not having had children is a major risk factor. Diabetes, being overweight, smoking. And then you might have heard a little bit about hormone replacement therapy. It is a risk, but it's a very, very, very small risk. Signs and symptoms of ovarian cancer: abdominal bloating, abdominal or pelvic pain, feeling full really quickly when you eat, urinary frequency, so having to go to the toilet really frequently. Also maybe some bowel habit changes, weight changes, fatigue, some lower back pain, nausea, unusual vaginal bleeding or very painful sex. And these would be persistent and unexplained. So there's some very vague symptoms in there. If you were diagnosed with an ovarian cancer, the treatment's similar. So major number one would be surgery, and that would be to remove or reduce the size of the tumour Again, there are some options to try and spare fertility, but it depends on how early the disease is found and how localised the tumour is. There'd be chemotherapy that'd be offered before or after surgery potentially. Again, some targeted therapies and hormone therapy depending on the biology of the tumour. Clinical trials at the moment are looking at immunotherapy and their role, more targeted therapies, and also maybe some chemotherapy in the abdominal cavity. We know that the introduction of these targeted and hormone therapies have improved survival in some groups, which shows back to that slide before where the 5-year survival and the 2-year survival is really improved. Again, side effects of the treatment can be acute, long-term, short-term, and could affect the whole body. So these commonly could put women into early menopause, again, may have issues with fertility, issues with sexual intimacy and sexuality. So some of the treatments can lower the libido, cause dryness of the vagina and fatigue. A lot of body changes, so alopecia, so that's hair loss from chemotherapy, maybe scarring from the surgery, bloating from treatments. Nutritional deficiencies, again, from the bloating or the having trouble with eating, chemotherapy. And there might be frequent hospitalisations, a very poor quality of life, and a major psychological impact from these treatments. Screening for ovarian cancer. There is none. No screening test for ovarian cancer, unfortunately. Over 50% of cases are detected at a late stage because of those very vague symptoms we discussed before and the lack of early detection tests and screening. Unfortunately, it can rapidly spread into that abdominal cavity, and curative treatment can be really challenging. So we really do need some early detection if possible. There has been investigated use of tumour marker blood tests and a vaginal ultrasound as a screening type test, but it was found not to be reliable or sensitive enough. There are some high-risk patients who might have some genetic predisposition to getting ovarian cancer, and they did some studies with them, and they show there might be a benefit for early diagnosis and improved survival using these blood tests and ultrasound if there's no risk-reducing surgery, which I'm going to talk about in a tick. So because there is no screening for ovarian cancer, what can we do? What can we do to get these cancers found quicker and have better outcomes? We can do some risk reduction. So very similar to what Dhanusha just talked about, diet and lifestyle, really, really important. Having children may be easier said than done. There's people who can't have children or choose not to have children. But apparently it would be a 30 to 60% risk reduction for those who do have children. Being on the oral contraceptive pill, breastfeeding, and this reproductive surgery that I mentioned. So there's an option potentially that you could have your ovaries removed if you do have those genetic factors that predispose you to that, but that's something you'd have to discuss with a surgeon and your GP. We need to intervene really swiftly, so anyone with any symptoms should go and see a GP really quickly. They would potentially do a blood test to look at this tumour marker and some ultrasound imaging. The GP then really should refer really quickly onto a gynae oncologist. This is a specialist. They will make decisions on the best approach, and it's shown that having a gynae oncologist for an ovarian cancer improves survival. We're also guided as clinicians by some optimal care pathways. So, patients really need to be investigated swiftly and get through to treatment really quickly for us to get the best outcomes. So support and resources. There's heaps of support out there for anyone diagnosed with an ovarian or a cervical cancer. There's Australian foundations, there's a cancer council. There's local support groups, and a lot of those support groups are now online through COVID and have remained online as well, which makes access a lot better. There's a local multidisciplinary team generally with every hospital, which is a group of people that will be looking after the patients to get best outcomes. And we're guided by guidelines, as I mentioned before. So these are national guidelines in Australia as well as international guidelines. America and Europe have a lot of guidelines. So what are the take-home messages from this? Survival is better with early stage cancers. The quicker we find these cancers, the better it is. A healthy lifestyle reduces the risk, really, really important. There are some risk factors there that are unchangeable. Our gender at birth can't change being born with a cervix and ovaries, and that being a risk factor. Pregnancy, you can't really win. You either have multiple pregnancies and are at risk for one cancer, or can't get pregnant or choose not to and are at risk for another one. Genetics, these BRCA genes and Lynch syndromes we can't change, and sex. You're not going to stop having sex just because you're at risk of cervical cancer. So we work on what we can control: smoking, eating well, exercise, and being involved in the screening programs. Really important to note, all persons born with a cervix need to be part of a screening program, so you need to discuss that with your GP if you haven't been involved yet. Know your family history, be proactive in your own health, know your body, get it checked, talk to your GP about any of these concepts. Just some references there, and thank you very much.
Thanks, Abby, for that comprehensive overview. Next, I'm delighted to introduce Dr. Negan Sedigat. Negan is a colleague of mine, an Australian specialist general surgeon with subspecialisation in breast surgery and surgical oncology, as well as endocrine surgery. She is breast surgeon certified in breast surgery and awarded professional certification with distinction in oncoplastic breast surgery at the University of Sydney. She is a member of both the breast and endocrine multidisciplinary teams, and she specialises in breast cancer and breast health, including a wide range of complex oncoplastic and reconstructive surgery, breast symmetrisation surgery, thyroid and parathyroid gland surgery, skin lesions, lumps, and hernia repair. Her compassionate approach occurs within a patient-centred care practice, together with a comprehensive team. Thank you, Negan.
Thank you so much, MQ Health, for putting the spotlight on women's health, which I think is a really important part of women's empowerment and advancement as well. So I'm really happy to be here today. I thought that I would firstly continue with the theme of exploring this wellness, and in particular the notions related to what defines breast wellness. One notion might be about how we feel about our breasts, and in particular that regardless of size and shape, every woman can feel great about their breasts. The other notion might be with respect to the prevention of disease, and where disease does occur, strategies to pick it up early. But I think overall, breast wellness refers to self-care, because it's really about caring for ourselves that influences how we achieve our full potential and our perceptions with respect to ourselves and our contributions within society. One of the biggest themes of breast wellness is to be breast aware. And being breast aware involves three components. One is knowledge, second is self-examination, and the third is participating in breast screening, and we'll explore each of those. So with respect to knowledge, it's important to know the family history of breast or ovarian cancer. It's important to speak with our mothers, fathers, grandmothers, grandfathers to learn more about the history with respect to these types of cancers, because we may in fact be candidates for genetic testing or personalised screening regimens that might be different to what is recommended for the average population. The other aspect is to know our breast density, and in particular, if we have extremely dense breasts. There's now a lot more public health awareness about how extremely dense breasts can increase our risk for breast cancer, but within the right context and conversations with specialists, a screening regimen can be tailored to ameliorate that risk. It's important to confidently know our hormonal history. How old were we when our periods first started? What was the age in which they stopped? How long have you been on hormone replacement therapy if you have been taking it? And finally, it's being armed with the knowledge about how to keep you and your breasts healthy. It's about knowing lifestyle strategies, which have already been discussed. It's about participating in breast screening and understanding what that involves, as well as knowing how to do a breast self-examination. So it leads me to breast self-examination. Really, it's important to start early, between 25 to 30 years of age. Because although breast cancer in women less than 50 years of age represents a relatively small proportion of all women or men with breast cancer, it is one of the situations in which the vast majority of women, approximately 80%, pick up the breast abnormality themselves, which then leads to the diagnosis of breast cancer. And the key with it is to pick it up early. So a lot of women assume that it's just about picking up a breast lump. That is one change to look out for. But it's about picking up any change, which can include a skin change, such as dimpling, or a change in the thickness of the skin or the colour of the skin, nipple change, such as inverting of the nipple or movement of the nipple towards one side, nipple discharge, which might include blood-stained discharge or clear discharge, as well as any breast lump. So what does self-examination involve? Well, firstly, before even touching, it's important to look. Look with the arms by the side and arms above the head. When raising your arms above the head, you want to note any change in the skin, such as dimpling or tethering. With the arms by the side, you basically want to see if one breast looks slightly different to the other breast, if there's a certain part of the breast that looks a little bit odd in shape, such as bulge or a skin change. Next, it's about feeling the breasts as well. So that involves using the pads of the fingertips, and it's about following a systematic approach to each breast examination. It can be any approach you prefer, either going from the nipples out to the edge of the breast, all over the breast, or approaching it in a clockwise direction, as long as it's the same way each time. And don't forget that with a breast examination, it includes examination of the armpits as well. So it's important to do this consistently, at least once per month. For women who are premenopausal, if you're still having your periods, it's important to time it about 1 week after the periods. For women that are postmenopausal, you can choose any time of the month that's convenient for you, such as, say, the first day of the month. Breast screening involves, and all women in Australia actually are encouraged and invited to participate in breast screening from the age of 40 and above. What does that mean? It means that every second year you have a mammogram. Now, that is the recommendation for women that are at average population risk. But for women who are at moderate or high risk, there is a consideration towards personalised screening regimen. So it may include more frequent mammograms and/or supplemental imaging, such as a breast ultrasound or breast MRI. This is what a mammogram looks like. It consists of 2 plates that provide an X-ray image in which the breast is placed between. This is an X-ray image that's provided, and this is what we refer to as a mammogram. This is one view. There are always 2 views at least provided. Breast specialists use the mammogram to make an assessment about breast density, as well as pick up any concerning features. So one of the features that might be picked up is a mass, which is this area here, comes out as more white. And the other feature is what's referred to as calcifications, which are small white specks that are picked up on magnified views. This is all completed during your screening mammogram. The aim of breast screening is to pick up cancer at an early stage when there are no symptoms of cancer. We know that when cancer is picked up at an early stage, it's associated with excellent survival with the appropriate treatment. So there we have it. To be breast aware involves, just to recap, knowledge, self-examination, and participation in breast screening. It provides us with the best outcomes should anything come up. I guess the next question that follows is, what happens when cancer is diagnosed? Well, firstly, your GP will refer you for a consultation with a breast surgeon. The breast surgeon will complete a full assessment and they'll characterise further the cancer biology and burden. Biology refers to certain characteristics of the cancer and the biopsy that help us target the treatment that might be needed, and burden refers to the extent of the cancer. Is it within the breast or has it gone elsewhere? The surgeon will provide you with recommendations for treatment, and every surgeon is part of a multidisciplinary team. A multidisciplinary team refers to all the health professionals that are involved in the treatment of breast cancer. The mainstay of treatments for breast cancer include breast surgery, systemic therapy, which can include chemotherapy or tablets or other types of systemic therapy, as well as external beam radiation therapy. There are other members of the team as well that might be really important for each case, such as psychology, genetics, lymphedema therapists, nutritionists, exercise physiologists, social workers, and fertility specialists, to name a few. But what's really important to acknowledge here is that the treatment of breast cancer is highly individualised, and it can involve a combination of any one of the above treatments that may be sequenced in multiple different ways. So, for example, it might be important in one case to have breast surgery first and then radiation therapy. Or in another case, it might be important to have systemic therapy first, then radiation therapy, and then surgery last. Or in another case, it might be systemic therapy and then breast surgery alone. I'm a breast surgeon, so I'm really interested in sharing with you the options for breast surgery for the treatment of breast cancer. Essentially, breast surgery can involve a lumpectomy, in which the cancer is removed with a safety margin around it, with or without oncoplastic techniques, or a mastectomy, with or without breast reconstruction. Breast surgery can sometimes also involve surgery to the armpit. That might be if at the time of diagnosis there is already cancer in the lymph nodes, or if it's important to assess the lymph node further to assess how much cancer might be in the lymph node, if at all. One of the questions I get asked a lot is, what is oncoplastic breast surgery? How's it different to normal breast surgery? Well, oncoplastic breast surgery, I would say, is part of normal breast surgery. It's just another technique that can be used. So its focus is still on removing the breast cancer while retaining the normal shape of the breast. And there are multiple options that can be used. So for example here, the cancer is marked out here. This patient really wanted to avoid a mastectomy. And so what is marked out here is using what we call a chest wall perforator flap to then fill the space after the cancer is removed. You can see she has a single scar in her recovery, and she has a good cancer outcome while retaining the shape of the breast. What we know is that breast conservation surgery, which is a lumpectomy with radiation therapy, has equivalent survival outcomes to a mastectomy. Again, oncoplastic breast surgery can be used in the setting of mastectomy. This is a patient with extremely dense breasts who had extensive cancer. She had a mastectomy, a nipple-sparing mastectomy on this side, with an immediate reconstruction. In this case, an implant was used. Oncoplastic breast surgery can also involve a complete reshaping of the breast. This patient had, unfortunately, bilateral breast cancers. Those were removed and the breast was reshaped. She had radiation therapy afterwards. So in summary, in terms of what can happen after a diagnosis of breast cancer, is that there are multiple different treatment pathways that are individualised both to the treatment of the cancer and the health goals of the patient. But ultimately, it's really important to engage in breast wellness. It allows us to feel confident about ourselves because we're empowered with the knowledge of how to care for ourselves. And importantly, if something does come out, we pick it up early and it's associated with the best outcomes. Thanks so much.
Thank you, Negan. And that concludes our wellness series, Women in Cancer session today. Thank you so much for joining us, and we hope to see you again soon.